Andrew Jawa is a Boston Sports and Shoulder Center, New England Baptist Hospital, and Beth Israel Lahey Health. Andy, take it away.
Great, Uma. That was a great talk. Really thought provoking. I'm going to be talking about value in shoulder arthroplasty. All I do is shoulder replacements. I'm the chief of shoulder arthroplasty at the New England Baptist, and this is really a case study in. Sorry, let me go backwards here. A case study with Avant-Garde on time-driven activity-based costing. It really started about 5 years ago. We'll go into some of the nuts and bolts of some of the stuff that was talked about earlier. So to me, these are my conflicts, highly relevant. I get paid by an implant company in royalties, and I'm an owner of an outpatient surgery center. Two things I'm going to be talking about in great detail. So do shoulder arthroplasties affect value, the implants? So we'll talk about time-driven activity-based costing, what it is. Dr. Kaplan's here, talk about this case study with New England Baptist, ambulatory surgery centers, and the outcomes, the numerator of this of value. So value and time-driven activity-based costing. So we all know this, value is outcomes over cost, and time-driven activity-based costing is really the gold standard for cost, defining it as Dr. Kaplan has figured out. This is a busy slide, but it basically shows that it's very complicated to figure out the process maps, the algorithms for which patients go through, and each individual cost. This is timed, unfortunately. So let me see if I can change that. And so it's very complicated to do that, and it takes a lot of expertise. In this case, that expertise comes from Avant-Garde Health. They have no disclosures with Avant-Garde Health, except they've helped me publish a lot of papers and see really good data. So the first thing that we saw was that when we got this data from Avant-Garde Health, this is what it looked like. For each individual surgeon, this is how much it costs to do a shoulder arthroplasty. This is me on the left, and all the other shoulder arthroplasty surgeons on the right. I'm certainly not the most cost effective, but we really wanted to break down what are the drivers of cost. And this led to our first paper. And what we discovered was pretty striking. I really didn't know this. The main driver for cost was the implant cost. So on the left is anatomic, and on the right is reverse shoulder arthroplasty. And that big blue is implant cost. The second thing, the purple, is personnel costs within the OR. Everything else, secondary. That was eye-opening to me. I really didn't know that. And that led us to sort of say, hey, how much does hospital length of stay cost? Everybody's like, get patients out of the hospital. It's going to be cheaper. And it is, but certainly nowhere near implant costs, maybe 10, 15% per day. Implant costs way more. That led us to then say, well, all right, is this maybe just shoulder arthroplasty, or is this all implants? And so we looked at this, and I'm sorry, this is timed for some reason, so I'll try and figure that out as I go. But we looked at the cases that had the most volume. So total knee, greatest volume, both at our institution and sort of globally. Total hip, next, and total elbow, the least amount. And it's very interesting when you look, total knee has the lowest implant cost per episode of care and the lowest cost overall. RSA, reverse shoulder arthroplasty, had really high implant cost and sort of proportional to, sorry about that, to the whole episode of cost. While total ankle is relatively uncommon, and that implant cost was the highest. So there does seem to be a general proportionality to how often this procedure is done sort of nationally and globally in the episode of cost and implant cost. So how does that affect profit margin? So we were able to go back and say, okay, how much were we paid for each episode of care in these individual cases, and how did the cost of the episode of care affect our profit margins? And this was done with Eric Smith, who was on one of these talks earlier. And this was fascinating. So it did seem to relate. So total knee, which had the lowest episode of cost, had the greatest profit margin. Total ankle, which was high cost, had a very low profit margin, and reverse shoulder arthroplasty had the least profit margin because we really weren't being paid that much more, even though the implant cost was much larger. So that was really eye-opening as well, getting to sort of the granular details of how much is an episode of care and how much we're making as an institution for this. And again, this is inpatient. Then we said, hey, well, maybe this is just at the Baptist and it's not at other institutions. So maybe higher volume places do better. So we worked with other facilities that use Avant-Garde, so Rothman and Gunderson. We said, well, maybe if they're higher volume, they're more efficient and they're lower cost. Totally wrong. And if you look at Hospital B, we actually don't have that actual cost. We have the index cost. Hospital B had the highest volume and the highest cost per case. Why is that? Well, maybe lots of hypotheses, but maybe people who are at the cutting edge do the highest volume, use the most expensive implants. And when we sort of broke this down, one thing came out in the regression analysis: implant, implant, implant. Whatever implant you use in a total shoulder, that by far outweighed everything else. So this was really interesting. And co-management, we talked about this earlier, became instituted at the Baptist. And that's a collaboration of surgeons and administrators to share gain sharing of any costs that we could have. So there's nothing better than putting competitive surgeons together and showing them their data. So this is the data. So these were our hip and knee surgeons who had monthly co-management meetings and said, hey, you are, and their names were there. This is you. This is how much you cost. This is how surgeon B, C, D, totally transparent. And people did not want to be the highest cost surgeon. So that led us to say, okay, look at all this variation in gray. That gray was the cost of implant. And I know a lot of facilities are going with one vendor, Zimmer, DePuy, whatever, and they get the best cost. But what they decided to do at the Baptist was do reference pricing. Say, hey, everybody can be here, DePuy, Zimmer, Stryker, just meet this low level of cost. And we were able to bring the cost down. Why? Because you got surgeons to buy in and they got some money out of that gain sharing. Now, that was great. The problem with this, and this alludes to what we talked about earlier, is it was a one-time thing. So I got a couple checks for this, but then all the savings that the BILH got from this, they moved it to Winchester, they moved it to BIDMC, they used these same reference pricing. We didn't get any of that. So the problem is sometimes there's a little bit of a bait and switch. And sometimes there's this first mover effect where you make some money early, but there's nothing else to cut down the road. And so I know Porter was talking about that, making that sustainable. That's one of the issues with gain sharing. You need to make it sustainable. The changing market, moving to ambulatory surgery centers. So this has been alluded to in the past, but one way surgeons are moving away from just being laborers is having other streams of passive income. I'm in a private academic institution. I can do this. And again, I'm sorry, this keeps advancing. And so CMS now has allowed for Medicare to be done at outpatient surgery center, not hospital-based surgery centers, but ambulatory surgery centers. And so that has changed the nature of what we do. And so I do a lot more as an outpatient. So you say, well, it's going to be cheaper to do it as an outpatient. And the reality is, using TD-ABC, Suren and Namdari show this, it's actually not. It's almost the same as doing it as an inpatient, maybe driven mainly by implant. So overall to society, Medicare is paying less, but the cost to the institution is not less. And so that money is just going to a different person, or less of it's going to them. Now, maybe it's better because it's going to the surgeon and there's some gain sharing there. But it is interesting because the question is, where is this money going to? Is this a race to the bottom? And the short answer is it is completely, because this is only going to last for so long until reimbursement for total shoulder as an ASC is going to drop, as we've seen in total hips and total knees. Now, we've talked a lot about cost, but we don't often talk about the other side of the equation in terms of outcomes. And the reason is we're extremely poor at looking at outcomes in the US. There's really very little incentive to do that. And, one of the fundamentals of value-based healthcare, as the leaders on this call have shown us, is that you need to follow, in this case, hip, knee, shoulder. You have to follow outcome through the whole cycle of care. And if you look, it's to mortality, or up top, reoperation or revision. The problem is reoperation or revision for a total shoulder is 10, 15, 20 years. We really don't follow that. And so value really cannot be calculated unless we have that, outcome or that numerator. We can look at other places like the Australian registry, which interestingly, they follow all their outcomes because it's one healthcare payer, which we don't have here. But we can see that things that are more expensive, like a total shoulder, or less expensive, have less good outcomes than things that might be more expensive, like pyrocarbon or RSA. But we don't have that outcome data here, but we can rely on others to show us that. But there's new technology, and maybe JP will be talking about this, that it's hard to look at that, like navigation. Here's another example of non-cross-link poly versus cross-link poly, which we can look at the Australian registry that shows, hey, more expensive products actually benefit. So in summary, total shoulder implants affect value. TDABC has impact. We do have difficulty measuring outcomes, and the move to ASCs really has changed this equation completely. I apologize because there was timing, which I don't believe I had, but sorry about that. But thank you. Hopefully I brought up some interesting points for discussion.